Hey, coming live to you from Cleveland, Ohio. And I want to talk about something that I have personally been saying a lot, but it's not my saying. And that is, we as clinicians should stop being so weird in functional neurologic disorders. And this is what I decided to call my talk that I am doing at the Cleveland Clinic this week, actually on Friday. Tomorrow is Thursday. We do an interactive lab session, which I'm super excited about, with a bunch of clinicians. I think almost 50 of them, actually. So watch out, Ohio. All the FND experts are coming your way. And then the following day, I'm one of the speakers, and I'm talking about that we should stop being weird in FND. So I want to give you a little preview of it, just a little sneak peek, and I want to share where this came from. So this particular article came out in 2024. It was a review article, the Royal College of Ophthalmologists in Nature. And this was called How Do I Manage Functional Visual Loss? And Neil Ramsay is the first author. John Stone is another author on this, and I believe this is actually his saying, and I put it in here. Let me show you this. I'm not sure you'll really be able to read all of it, but I'll read it to you. So it's from this paper, and he says, and let me just bring up the whole quote. In general, what tends to go wrong in the explanations of functional visual loss and FND more widely, so not just functional visual loss, is that clinicians behave and talk in a way that is in variance with their normal practice. In essence, they do things that are, quote, weird. And they do. And they're perceived as such by the patient. To correct this, all that needs to happen is for the clinician to explain this disorder in the same way as they do every other condition. I love this because I'm going to say, even for myself, when I first was working with folks with FND, I too was weird. I felt like, well, this is different. I should act different and I should do different things. And actually, no. As clinicians, we don't need to be weird in FND. And we can really understand it and approach it just like we would in neurologic rehabilitation. And sometimes it's the getting weird that really throws things for a loop. And in fact, really what I think is important is it destroys trust, because you as the clinician are going, gosh, things are really weird here. I'm not sure what to do. And you start doing weird things that you wouldn't normally do in clinical practice. And the patient perceives that. They know you're being weird too, because you're doing weird things. So this is, I want to bring it back to the paper here, particularly as the inspiration for the talk. And then after I have my day here, I'll do another live and go through a couple of my slides from the talk as well. And by the way, as usual, comments, questions as we go on here. I love to hear from you. And I just wanted to note, someone just said, I just managed a VO2 max test with my FND. Hooray! I'm cheering you on there. VO2 max testing is no joke. So congratulations. That's pretty incredible. So let me come back to the paper. So I'll just bring it up again here. How do I manage functional visual loss, which, by the way, I highly recommend this paper for anybody seeing people with visual issues. It was written for the ophthalmologist, but I think there's so much that we can all gain from this. And in particular, there is a couple of great figures here. One that talks about the kind of background and the potential of how functional visual loss might occur. And this is where they really emphasize too that the ophthalmologist or physician or any of us as clinicians, this is where we could stop being weird when it comes to the diagnosis of FND. We should approach the diagnostic process just like any other disorder, which is to approach it with laying out, these are the positive clinical signs. So typically, I'm not a neurologist, but I have been in the neurologist's offices many times. And the normal way you would go about diagnosis is you say, this is what you have, right? So you have functional visual loss. Here are the positive signs of functional visual loss that you have. This, and this. You might also have migraine. You might also have a stroke. You might also have MS, but you also have functional visual loss. So you state it as it is. You talk about what positive signs support that. And in this article, they also recommend doing the other tests that you might do, of which I'm not very familiar with because I'm not an ophthalmologist, but the other testing that you might do because FND is so common with other disorders. So not just to rule out other disorders, but to actually look for comorbid conditions. If somebody has functional visual loss, it's important to look to see if they have another condition alongside of it. So to do testing to see if there's comorbid conditions and to talk about the prognosis for functional visual loss, which, by the way, they outline in this paper is very good. In one study, I believe it was 78% of people went into remission, which is great. I think there was another study in pediatrics where 25% of them, it was in remission within a year. So really good prognosis for functional visual symptoms. And then to talk about what might have been the predisposing factors, the precipitating factors, those comorbid conditions, and kind of put those all together to help explain what is happening. And much like, by the way, many other disorders, we don't fully understand why this occurred, right? So like many other neurologic disorders, there's genetic factors, there's environmental factors. Every person is different. And so we might not know all of those things. And that's typically not part of the diagnostic explanation, is like, let's figure out exactly what caused it for you. But let's start down the treatment pathway, right? So what I want to point out in this picture is we've got those predisposing factors, and for functional visual loss, we see things like eye conditions. So that makes sense. Brain conditions like migraine. That's something that I think I've seen the most, because you could have an occipital migraine that causes visual symptoms. Anxiety, depression could be a predisposing factors, but it doesn't have to be. Genetic factors, autism and ADHD, and sometimes there's nothing that we can find predisposing. And then there's these precipitating factors. So this can occur, and I'm glad they put this in here because this is where I think I see it the most, is in traumatic brain injury. So concussion or other brain injuries, migraines, and then obviously eye conditions are things that we see. And then we have these comorbid conditions that should be screened for, and then factors that perpetuate the symptoms. These are things that should be screened for as well. So we see things like medication. This is where, again, we could stop being weird. Medications have visual side effects in some people, and they should be screened and looked at as a potential mechanism to maybe there's a switch up of a medication or something like that. So, and then again, treatment. Functional visual symptoms can improve. And it's not that everybody needs like developmental vision therapy, although that could be indicated. But sometimes that's not what is needed. So the good news is that rehabilitation efforts can really help functional visual symptoms. So that was one piece. And then they also talk about treatment options. And again, I'm not an ophthalmologist, so this was really eye-opening to me to look at these treatment targets. And I know it's really tiny on our screen here, so I'll pull it up here. And what's kind of cool is that these make a lot of sense to me, and they are like hand in hand in line with what our dizziness guru team, Jamie and Catherine, talk about with visual motion and visual sensitivity. So the first one is optimizing visual input. So we do understand when folks might have like a dizziness event, for example, they might become quite visually dependent and visually sensitive because of that visual dependency, and therefore could develop some functional visual symptoms. So optimizing that visual input. And this also means let's treat the comorbid conditions like migraine. I will never forget that a patient told me that a physician said that they would not treat her migraine because she has FND. Two different things. Migraine is not FND. FND is not migraine. They both need treatment. Controlling and managing migraine can really help with FND if folks have migraine. So optimizing visual input, challenging and altering brain predictions. So we understand FND as kind of the brain predictions gone awry. There's an overweighting of brain prediction. And this needs reprocessing. This needs integration. And I would say sensory integration, right? Because the visual is processed alongside of the vestibular and the somatosensory and the interoceptive and so on. They also share some studies about occipital transmagnetic stimulation. So I found that really interesting. And then addressing some of the things that make it harder to improve, like photophobia. That's something that we see a lot as well. And gradually reintroducing activities. What I want to say, if you look at the bottom, there's the bottom-up sensations too. So I love that they kind of are looking at the top-down and bottom-up, normalizing the visual input so that those predictions can be updated accurately. And this is exactly what we would do for the motor system or the sensory system. So not really different, except it's the visual system. So I thought that was great. And I highly, highly recommend this article for you all. So I'm going to bring it back up here just so you can grab it. And if you're not on our newsletter, I share all of our videos and resources in a newsletter every week. I send one to clinicians on Fridays and one to patients on Mondays. If you're not on that, go to reactiveeducation.com. If you are a clinician, or reactivept.com if you're a patient. Sign up for the newsletter. I will send out the link to this, as well as other things that I'll be learning about and sharing this week at the Cleveland Clinic. But again, this article just from this year in the journal Nature, and it's called How Do I Manage Functional Visual Loss? So this really got me inspired to talk this week at the Cleveland Clinic about how we as clinicians can stop being so weird in FND. And yes, they were talking about it in the visual system. I'm talking about it really more from a movement and a rehab standpoint, but same message. We as clinicians you know what? We didn't learn this in school. It defies some of the norms of what we know and understand. It makes sense that we would act kind of weird about it because we didn't fully understand it. But let me tell you, we understand a whole lot more now. And I think it's time we stop being so weird. So that is my message for clinicians. And I'm just going to scroll through and make sure I didn't miss anybody else's question or comment here. And I would love to hear too from other patients. What have clinicians done that have been kind of weird and maybe diminish some of your trust in healthcare because they were acting so weird or doing weird things that they wouldn't normally do with other people. So I want to hear that from you because I learned a lot from you. And I think there's so much that we can do. That is why I am talking at Cleveland Clinic this week. And because I want to keep spreading the word about FND, about what we can do, about what we as rehabilitation professionals can really do to help people, and to help us all just like shed that layer of weirdness about what we do and really get in and help people get back to life. So that's why I'm here. I'm very, very thankful for the invite and the opportunity to keep spreading the word and follow along this week as I'm also always learning something new. So I'll be learning a lot at this symposium as well, and I'll be sharing it with you. And I hope you have a wonderful night. Thanks so much.